Good evening to all the aspirants present here. The topic for today is Genitourinary Class 3. Our speaker is Dr. Anand Joshi, sir. He is a consultant intensive physician at Gamman Hospital, Hyderabad. Sir, you may take over. Thank you.
Thank you, Sana, and all the students. Welcome back to the third session. As in the beginning of the sessions, when we did the first two classes, we realized how extensive uh, and the detail is this HIV/AIDS and genitourinary sepsis there. We have touched the topics previously of the gonorrhea and other sexually transmitted disease, and then we had this elaborate class on HIV and AIDS. To be honest, a lot of physicians who practiced in 1990s and 2000, including me, learned a lot of my medicine with on HIV and AIDS patients, because there is so much to learn. There is so much of interaction, so much of infection, infectious disease things, opportunistic infections that comes across when we have a depressed immunity. Same thing holds true when you are dealing with a patient with a cancer or any other immunocompromised state. So I will just have a quick review that initially we went through this epidemiology, transmission, and clinical overview. We had uh, seen the routes of transmissions. We have understood the virus, how it is a double capsulated, it's got an RNA, and then how it is gifted with an enzyme called reverse transcriptase that enables it to go inside a host and then get embedded in its DNA and then break out and then come back. So this is what I was referring to. I think somebody is having a bit of a doodling. Then we have seen how the pathogenesis of HIV is primarily affecting the CD4 count, and it unleashes all the problems symptomatic as a primary virus and causing other inflammatory state. We have seen a bit of a natural history. We have seen HIV testing. We have understood what are the special testing considerations and few guidelines. We have seen previous talk, the clinical spectrum. It might be because of the direct effect of the primary HIV infection. We have seen how the immune dysfunction happens, and we have yet to see the opportunistic infection in detail. We spoke about age-defining conditions, not always the um, infection which is caused by HIV virus will present as a specific or discrete sign and symptoms, but they may come as a first infection or a cancer, which otherwise an immunocompetent person will never ever have. So when you get to see these infection, you need to think whether there is an underlying HIV/AIDS happening with this person. We have defined the AIDS, we have seen what the primary HIV infection is. We also have seen primarily how this HIV virus affects the organ system. It's a neurological effect, ocular, mucocutaneous, um, hematological, gastro, renal, respiratory, endocrine, cardiovascular, etc., etc. We have seen the management of HIV infected patient, and this was completely focused on antiretroviral therapy, because this antiretroviral therapy itself has so many side effects. So we need to carefully monitor them. Also, these people, as we know that viruses are very smart, so they would have a drug resistance, and we spoke about that. We spoke about how to initiate the ART, what are the goals of ART. We spoke about how the initial assessment of an asymptomatic patient, then monitoring of asymptomatic patients, how the viral load and CD4 count go up and down. We also saw about a sick HIV patient. Then we went through the classes of various medications, its regimes, its monitoring, its resistance, mechanism of drug resistance, drug interactions, etc. They also seen its complications and a special situation including immune reconstitution syndrome. Um, so we stopped at this slide last time, and then what were remaining were the opportunistic infection, specific infection, and malignancy associated with HIV, which I'm going to cover in today's talk. So if you understand closely that we know that the CD4 counts and some B cells gets infected. So that's basically in the current situation or scenario with this familiar term, our army, the body army is getting suppressed or getting destroyed. And so we are, our body becomes a country without any army, and that gets susceptible to all sorts of infection. You think often it is possible. We get bacteria, we get virus, we get protozoans, we get fungus, all sorts of things. However, this was true when we in the initial years in 90s and early 2000s, when highly effective antiretroviral therapy, also famously called as heart therapy, was not getting introduced. But with the introduction of the heart therapy, the things have now, before a person gets into severely immunocompromised or immunosuppressed state, we are able to balance his immunity out with heart therapy. But in bargain, what we have found is when a person is severely immunosuppressed and he gets an infection, the major body defense mechanism for our infection is the body's inflammatory response to any invading organism, whether it's a virus, whether it's fungus, protozoal, or bacteria. Now, in the presence of HIV, when these things are not there, and at the time of the diagnosis, if the patient is harboring this infection, then we have no clue whether this is primarily an HIV or there is an additional super added infection. That is because the body has not shown any response. There is no fever, probably there is no any symptoms. But when, or maybe there is some response which is not adequate. So what we saw that when these patients were given heart therapy and the HIV viruses came down and the immunity started restoring back, there was a sudden inflammatory response. And to a treating physician, it appeared that the patient is worsening. But that was not actually. This, they termed it as IRIS syndrome, that is immune reconstitution syndrome, which confused the physician who is treating an HIV that whether I am doing something wrong because things have started suddenly worsen. So this aspect needs to be kept in mind when you're treating any opportunistic infection, and this should be on the top of your mind when you're treating simultaneously HIV and the infection. As the common sense goes, if the patient is having an HIV and he is known case of HIV, immunosuppressed state, the prevention remains the cornerstone. So before we go to any individual infection, let's talk about the prevention. Obviously, personal hygiene, avoidance of any avoidance of the patient going in any area where the communicable diseases are very high. Hand hygiene is the most important thing you would be advising to any HIV patients. There are few guidelines for immunization, which I will show you in the next slide. Chemoprophylaxis has also revolutionized for certain infections. This is the primary and the secondary chemoprophylaxis, and it has shown that pneumocystic cerevisiae, toxoplasmosis, and Mycobacterium avium intracellularly, these organisms, when respond very effectively to the primary prophylaxis. That means the chances of the patient getting this infection is dramatically reduced if the patient has a primary prophylaxis. However, primary prophylaxis is not recommended normally for any herpes, fungi, or cytomegalovirus because it has shown not to be useful. So, whom should you give the chemoprophylaxis? As per the guidelines, any person, any HIV person, positive person whose CD4 count is less than 200 warrants chemoprophylaxis. So the 200 is the golden number you need to remember. I just spoke about the immunization. So as we know, this is a quite an immunosuppressed state. There are certain vaccines which can be given, certain vaccines which cannot be given, and certain vaccines which are like can be given in certain situations. So it goes unsaid that all inactivated vaccine can be given to HIV because your immune system is so poor, you cannot give a live vaccine to them, which is supposed to induce a memory cells. So you can't give that. So the first column tells vaccines that can be used in all the HIV patients, and they are all inactivated. That is Hep A, particularly Hep A, Hep B, influenza B, Japanese encephalitis, meningococcal, polio, rabies, typhoid, tick-borne anthrax, cholera. Cholera live vaccine, influenza live vaccine, polio live vaccine should not be given. So if you are confused, just remember that all the live vaccine cannot be given, whereas all inactivated vaccine can be given. Now, vaccines that can be used only in asymptomatic HIV infected adults with CD4 count of more than 200 are the MMR, varicella, and yellow fever. These are only three, right? So this is an important thing which you need to keep in mind, and even from the exam perspective. So let's check on to the specific conditions associated with HIV infections. So we'll start with a fungal infection. One of the most studied, talked about, spoken about are the PJP or PCP infection, pneumocystic carni, or the new name as it's no longer a new name now. It's a pneumocystic cerevisiae pneumonia. This fungal, or it's an actually a borderline fungal in terms of class, it's usually seen in when there is the CD4 count is less than 200. So this is subjected to the primary prophylaxis, and a good hard therapy would push the CD4 count above 200, and the infection or the infectivity goes down. This fungus actually damages the alveolar epithelium, reduces the compliance, and induces an ARDS-like picture. Patient's presentation is for any other pneumonia like shortness of breath, dry cough, fever, tachypnea, tachycardia, cyanosis, and you can hear either fine crackles or there could be absolutely no abnormality. Now, the thing about this PJP in the diagnostic is that the chest X-ray initial or the early infection may be absolutely normal. So you may be fooled by absolutely normal X-ray, and then the patient, and you will start thinking of a heart failure or some any other thing. But no, be careful when you're doing that. The another presentation might be either it's a normal or the chest X-ray might reveal over the period of time bilateral perihilar interstitial infiltrates, which eventually gets into a full-blown bilateral ARDS. These patients, when you do high resolution CT scan, they would reveal these ground glass opacities, and that would might be a diagnostic. Usually the diagnostic is by bronchoalveolar lavage or blood PCR. Sputum staining of the silver stain or the immunofluorescence would also reveal it. But most of the time we are doing either BAL, that's a bronchoalveolar lavage, or blood PCR. The treatment is simple with cotrimoxazole and for 3 weeks. The patient who are acutely hypoxic responds very well to the hydrocortisone standard dose. You don't need to pulse them, but the shortness of breath and the cyanosis responds very dramatic for these patients. Those patients who's got allergy to cotrimoxazole, trimethoprim, sulfamethoxazole, you have pentamidine, dapsone, atoquinone, plus minus clindamycin or primaquine. Chemoprophylaxis you can give as a cotrimoxazole 960 milligrams 3 times a day uh, for a week. The second important fungal infection is Cryptococcus neoformans, and the most common presentation in HIV patient. You can get Cryptococcus in other immunosuppressed state, but in HIV patient, they most commonly present as a meningitis. Otherwise, they can come as a pulmonary or a disseminated infection. Typically, this is acquired from the bird dropping, and history would give you a clue about the possible source of the infection. The diagnosis, you have to do a CSF. Infective CSF would be the picture, and you can have an India ink preparation, CSF antigen for a Cryptococcal neoformans, and the culture would reveal the organism. The treatment is a tough nut. It's an amphotericin B plus minus flucytosine or IV fluconazole for those who are in. But that's again, it's not a first line. First line is definitely an amphotericin B. Now, if the patient is not on heart and you discover Cryptococcus neoformans, try to hold your heart therapy at least for 2 weeks. First, treat the patient at least for 2 weeks and then start. Because if the patient is coming with a meningitis, with a headache, then starting a heart early would induce iris. And when the iris sets in, you may get worsening of the symptoms for the in terms of neurological manifestation. So be careful when you're trying to start a heart for a Cryptococcus neoformans, because at some point you will have to start it because the patient is severely immunosuppressed and you have to start heart. But when to start? Wait for at least 2 weeks. The third famous are the Candida infection. Now, the Candida infection, unlike just an oral thrush, it of course it comes as an oral thrush, but here it is involves right from mouth till down the whole whole colon. Commonly, we see it as an oral thrush. Along with that, we have an esophagitis and vulvovaginitis are the very common. Candida albicans are most commonly seen, but cruzi and the glabrata are the one which you should be aware, because cruzi, Candida cruzi is a fluconazole resistant. So even though you start treatment fluconazole, you think that you have covered Candida, but if it's not responding and you don't know the typification, and if it turns out to be Candida cruzi, then it's not going to work. Here, the prevention, again, you improve your CD4 count, decrease your HIV viral load with the heart treatment, and the candida infection will automatically be taken care of. Aspergillus, which we would otherwise think would be common in HIV, is actually very rare. Unless these HIV patients have cofactors like transplant, neutropenia, or the patient is on high dose corticosteroid for some else. Classically, it came as the same way as in other immunocompromised patients. It starts from the sinuses, gets into the lungs, and voriconazole is a preferred treatment with the alternative being amphotericin or caspofungin. Um, Few fungal infection are endemic to certain area like North America, Southern America, and some part of the European, where you get histoplasmosis, blastomycosis, coccidioidosis. These are all having a very specific geographic endemicity, and the risk um, you can calculate if the patient has traveled to that geographic area, or having geographic any other exposure. The presentation of all of these are like any other fungal pneumonia or systemic infection, and the treatment is amphotericin B with the standard dose. So these were the fungal infection. The next one is the protozoal infection. Toxoplasma, again, this is, as I said, few organisms will ring the bell to search for HIV. If in fungal infection, if it was your initial PJP, then for protozoal, it will be a toxoplasma. If you come across any toxoplasma, then you will surely go back and see that whether the patient is HIV or not. Now, the toxoplasma can, or most commonly, is a reactivation in a seropositive patient, especially in the UK data, and presents as a cerebral encephalitis or cerebral abscesses. The symptoms are like seizures, focal signs, clinical signs, and encephalitic features. The classic imaging when you do a CT or MRI is a multiple ring enhancing lesion. Now, multiple ring enhancing goes more in a favor of a toxoplasma. However, it doesn't, if there is a singular, it's completely rule out. However, if you are looking at a singular ring, besides toxoplasma, you should look for either tuberculosis or lymphoma or cryptococcus in this patient. The treatment is by pyrimethamine, sulfasidine, plus folinic acid, or there is a clindamycin regime. Again, in these cases, you need to start, wait for 2 weeks before you start the heart treatment. Now, the confirmation for toxoplasmosis, you can get it either through the CSF or one, the imaging is highly suggestive. Second is the CSF. It's a very tricky to do because if the raised intracranial pressure is there, then the CSF becomes contraindicated. However, having an IgG, IgM in the blood is not going to be that useful. The other protozoal is a cryptosporidium, sporidiosis or microsporidium. It has more of an gastrointestinal effect with life-threatening gastroenteritis, acute bloody diarrhea you can get. And the diagnosis is by acid stool, acid fast smear for acid fast bacilli on the stool, and the biopsy. Now, the treatment, again, is there is no specific treatment for this. So improving the immunity would be the mainstay. There is some limited efficacy about nitazoxamide. I have never used it, so I can't comment on that, but this is given in the literature. Leishmaniasis, which is endemic in Africa, South America, and the Mediterranean, comes as any other leishmanial infection, fever, weight loss, splenomegaly. The diagnosis is based on the bone marrow or the splenic biopsy, which is I have never done it, but that's what is given in the literature to we locate and amastigotes. Here, the serological test for leishmania is unreliable, and the treatment is via liposomal amphotericin B and the heart therapy. Coming to the viral infections, now a lot of viruses gets transmitted because they have shared transmission routes. What we have seen in the sexually transmitted diseases, a lot of viruses get transmitted. So commonly we see is hepatitis or exchange of secretions, hepatitis B, C, cytomegalo, herpes, Epstein-Barr, JC virus, and HPV virus. The thing about the HIV and this concomitant viral infection is that the these viral infection, which otherwise would be having an indolent course, are much more ferocious in an HIV patient, and it increases the morbidity. And many times when you treat this viral infection with other antivirals, it interacts well with the heart therapy and complicates the treatment. So this becomes an important as we are treating this patient with the heart therapy. So let's take the most common things are like the hepatitis B and C co-infection, and common with MSM drug users and transfusion recipient. The problem is that as compared to a non-HIV patients, the hepatitis B is much more aggressive, hepatitis B and C, and it causes faster liver damage and cirrhosis and has got higher mortality. Again, antiretroviral therapy, hepatotoxicity gets added to this liver damaging viruses, and the risk becomes higher. It becomes always becoming confusing whether this is because of the primary hepatitis or whether it's a hepatotoxicity of the ART, and that becomes an absolute challenging affair. Now, again, in these patients, we need to be careful about the alcohol advices. In hepatitis B particularly, what happens is the HBE clearance is substantially reduced. Hence, the chronicity and the infectivity of hepatitis B remains high, and this hepatitis B getting into a chronic stage becomes much high. Here, the antigen, antibody, or E level measurement doesn't help. So it's straight away hepatitis B DNA levels becomes the guide for the treatment for Hep B. Again, there are few overlapping medications for hepatitis and HIV, so that comes to our advantage. So if you're starting the heart, then tenofovir, lamivudine, emtricitabine based therapy would be useful as it has anti-hepatitis B activity. Again, heart may trigger HBV flare due to iris, which goes unsaid. Hepatitis A vaccination can be concomitantly given if not given. For hepatitis C, similar, it gets accelerated in HIV, and this is because of the blunted CD4 response. The heart therapy, when you start for the hepatitis C patient, will not have so good response in terms of increasing CD4 count if there is a concomitant hepatitis C. So if the treatment of hepatitis, because there are no overlapping medications, we need to go with the pegylated interferon and ribavirin, even if the CD4 count is more than 200. Now, in terms of treatment, you treat HCV first if HIV is stable. However, if the CD4 count is low or high viral load is there, then HIV treatment gets precedence. Now, when you do this, it increases the risk of hepatotoxicity. So, protease inhibitors are the group of choice for the heart when you are treating an HIV with hepatitis C. Again, vaccinate against HBV and hepatitis A is to keep in mind when we are treating with a hepatitis C. The next common virus which will come across in HIV patient is cytomegalovirus. Now, if somebody is you're suspecting a cytomegalovirus, or if you want to suspect some unusual things which you're not getting hands on, and look at the CD4 count. These are the usually very, very severely immunosuppressed. CD4 count is less than 100. And this cytomegalovirus is wide. It can come in any form, particularly if you're looking at a retinitis, or if you're looking at a bad gastroenteritis or colitis or encephalitis, the high chances you are dealing with an HIV, CMV infection. Now, we don't have any specific treatment for that CMV. Only the heart reduces the CMV incidences. For the CMV retinitis, if you're looking at it, you're looking at more, I mean, the worst case scenario, and the CD4 count is less than 50. The presentations are usually with the floaters or visual loss. And on ophthalmoscopy, there is a classic pizza pie on the retina. Most of the time, its diagnosis is clinical, and we treat with valganciclovir or ganciclovir or foscarnet. They may require a maintenance therapy. There has been a small implant in your for the retinitis, the intravitreal therapy or implant being placed, which help for the faster resolution. Wide range of GI and neurological manifestations are seen, particularly CMV esophagitis, ulcerations, ileitis, colitis, and hepatitis. Comes as abdominal pain, diarrhea, ulceration, severe acute gastroenteritis. The CNS involvement is via CMV encephalopathy, polyradiculopathy, and usually these people have a very, very poor or a bad prognosis. We do treat them with the ganciclovir and the heart therapy. However, the outcome is very poor for these people. Immune restoration, again, is the key. Yes, people do respond, but again, as I said, the mortality and the morbidity is very high. What about herpes and varicella? Again, the severity of these viruses is very high, especially with the low CD4 count. Now, instead of a pustular, typical pustular things which you see in this group of viruses, you see more of an ulcerative region. This will be either a genital, oral, or anal, and these ulcers shed virus for long period of time. When you talk about varicella zoster, it comes as a multi-dermatomal. So whenever you see a multi-dermatomal lesions, think that this patient is having an HIV or not. And this longer duration of the viral shedding. Treatment is with acyclovir. Sometimes we do come across some resistant strain. We have to keep in mind, and you can use a foscarnet for that. Again, using heart therapy and immune restoration is helpful. Some of the viral infections are important in HIV. Why? Because these are the viruses that induce cancers in HIV. Human herpes virus 8 induces Kaposi's sarcoma. Epstein-Barr virus causes lymphoma. Hodgkin's, non-Hodgkin's lymphoma, wide spectrum. Oral hairy leukoplakia is the classic you see in HIV patients. Human papilloma virus induces warts and cervical and anal neoplasia. John Cunningham virus, JC virus, is a polyomal virus. It causes a white matter involvement and the changes, and it causes rapid neurological decline. We don't have much of treatment on that. Uh, some reports suggest that the heart therapy, if you start the heart therapy, then uh, it has shown some improvement, but most of the time, these people die. Coming to bacterial infection, now even when you have a common people, we get a lot of bacterial infection. Those people with an immunosuppressed state, they are much more susceptible. And it goes unsaid that because of the unpaired immunity. The CD4 T cell depletion affects the cell mediated immunity, and the B cells dysfunction. It's not only just a CD4, it's a B cell dysfunction induces IgG2, impairing response to an encapsulated bacteria. That is something which you need to keep in mind. Infections may occur in early HIV also. So even the CD4 count is high, and even though the viral load is not so high, there is a functional decline in immune system. So these people can get early infections. As I said, as the response is for the CD4 and susceptibility to encapsulated bacteria high, the common organisms you will come across are the encapsulated bacteria, namely staph strep and H. influenza and Moraxella catarrhalis. Usually, as against a non-HIV or immunocompetent patients, these bacterial infections in HIV often present as a disseminated. However, good thing is they respond very well to the standard antibiotic. We don't always have to go to a higher antibiotic. So if you're looking at an HIV patient and if you see a atypical bacteria, or if you're treating for some skin infection, or you're looking at a typhoid, the ceftriaxone or azithromycin is still fairly good enough to treat them. You don't need to always jump onto tigecycline or meropenem or cholesterol. No. So their response to the standard antibiotic is quite okay. However, you also have to keep a vigilance because the risk of recurrence is very high, and some of them may require long-term prophylaxis. One of the interesting co-infection, or one of the coefficient which is much talked about and which you will come across, especially if you're practicing in India, is a Mycobacterium tuberculosis. High prevalent regions, especially Africa and Asia, complicates the matter. And since it's airborne, it can present early in HIV. Because of the endemicity, TB can come as a reactivation from the latent TB or a new infection. And the pattern of the disease differ with the immunosuppression. So if you have a well-preserved CD4 count, more than 300, similar to HIV negative patients, the presentation will be like a standard any pulmonary infection. But if there is a more advanced HIV, then you are looking at atypical presentation. There will be a pulmonary presentation without cavitation, prominent hilar lymphadenopathy, extrapulmonary TB affecting lymph nodes, bone marrow, liver, all these things, all the weird sorts of things which you can think of can present in HIV. Again, for any tubercular diagnosis, it is the tissue sample is the best. Culture, it takes long time. We do have the PCR techniques now to do that. Do not go with any kind of skin testing, because of the HIV, and the skin testing relies on your immunity, and in HIV all your immunity is down. So all the investigatory parameters, including MAN2, which involves skin testing, are useless. So either you go with the tissue sampling, where you classically see the glomerular, what do you call that, pathological feature. Uh, Sorry, got a thought block. Anybody who can help me? What is a pathological tissue diagnosis for TB? Just checking it.
Langerhans.
Langerhans cells, and granuloma formations. So those will be the classic ones which you will get it, or quantiferon gold. That is what would be the diagnostic. But remember, MAN2 and any of those things are useless anyways. The treatment would be a standard regime, 4 drug ATT, same regime you have to start off. However, these
हे टाकून द्यायचे का तेवढं एकच राहिलं तेवढं
so the standard regime would be for the standard ATT. However, you will have to revise yourself, closely follow clinically for the extended duration instead of 6 months or 12 months. The biggest challenge when you're treating a HIV patient with a TB patient with an HIV are the drug-drug interactions. Rifampicin is enzyme cytochrome 450 inducer. So protease inhibitors gets interacted, which are metabolized. So almost all the ARTs, lot of drugs gets metabolized in the liver. So the liver is now heavily loaded in terms of medical medicines from the TB side and from the HIV side. So the toxicity goes up. So we have to be very careful and we have to be very, very judgmental when we are trying to treat the TB and HIV, especially monitoring for the overlapping toxicity for the liver, GI, and neuropathy. Nothing troubles you more nothing troubles you more as far as iris syndrome is concerned, particularly more than in TB with HIV. So this is the most troublesome part. You've got a TB patient, he's on anti-TB treatment, then you start on hard, and this patient then suddenly comes with a worsening of the symptoms, cough, expectoration, the chest X-ray goes worsen, and we think that we don't know what is happening. So these things are because of the immune reconstitution. So before you jump that whether your TB regime is failing or HIV is worsening, try to consider that this might be an iris syndrome. And this has to be carefully managed by the specialist. And most of the time you use the steroids in these kind of cases. So balance starting hard with the TB treatment is something you need to know and understand. Start hard 2 weeks after TB treatment if CD4 is less than 100. So if it's a severely immunocompromised, then obviously you have to start hard. But you first start TB treatment and then wait for 2 weeks and then introduce the hard slowly. If the CD4 is more than 200, then you can delay the treatment of HIV. The treatment for TB takes precedence over HIV, and you can delay it as late as 6 weeks. Mycobacterium avium intracellular. This is the organism which many a times is overlooked or it is never thought about. Now this is a very low pathogenic saprophytic bacteria which is ubiquitous. It stays everywhere. Soil is there, on inanimate object everywhere. It is particularly seen in the late stage of HIV. So if you get a MAC or microcellular avium intercellular organism, then you have to assume it that this is a very immunosuppressed. CD4 counts are very low in this HIV patient. It comes as most of the time as a disseminated infection causing fever, weight loss, anemia, and GI symptoms. It is extremely difficult to diagnose. Blood, bone marrow, usually it is seen in a bone marrow as acid fast bacilli on the liver culture, but it's mainly the culture takes long time for any mycobacterium. Here the treatment, it doesn't respond to your standard AKT regime. It has a different set of antibiotics, rifabutin plus plus macrolide, either clarithromycin or azithromycin plus ethambutol. Amikacin can be added. The prophylaxis can be given with rifabutin or azithromycin. Other bacterial like influenza A, it's more severe in HIV and can be treated with oseltamivir. Salmonella is a non-typhoidal, causes disseminated cystitis, osteomyelitis, and it's treated with ciprofloxacin. Staph aureus skin infection is common, and periodontal disease, especially necrotizing periodontal disease, which is very painful. Next is the parasitic and the skin infections. Strongyloids, scabies, superadded bacterial infections are common, need to be kept in mind and treated appropriately. The last section is that of the neoplasms. HIV per se increases the risk of some of the cancers, and these cancers are, if you get it, they're either AIDS defining or frequency of other cancer is increased. So AIDS defining cancers are Kaposi sarcoma, non-Hodgkin's lymphoma, and cervical cancer. Other cancers whose frequency increases are liver, anal, Hodgkin's lymphoma. All of them, like especially the AIDS defining cancers, the incidence gets reduced with heart, and longevity increases with the age-related cancer risks. In terms of Kaposi sarcoma, as I mentioned previously, caused by human herpes virus 8, is more aggressive in HIV positive individuals. It is also found in other immunosuppressed state, but it is age-defining for HIV. Its presence as a pigmented, well-circumscribed skin lesions. It's got a multicentric tumor spindle and endothelial cells under the microscope. It affects skin, lymphatics, lung, GI tract. It not only case involving the viscera like GI tract, liver, spleen, or lungs or colon has got a worse prognosis or a very bad prognosis. Heart reduces its incidence and induces regression. The treatment for the superficial will be with the local radiotherapy. Systemic chemotherapy is available, but still under experimental. The mainstay remains the improving your immunity with the heart therapy. We have HIV-associated lymphoma. It's mostly non-Hodgkin's B cell, large B cell type. Frequently extranodal, comes in brain, lung, and GI tract, strongly linked with Epstein-Barr virus. Often aggressive, it rapidly progresses and has got a very, very poor outcome if it involves cerebral. Early stage of the lymphoma responds better to standard lymphoma therapy. The last but not the least is the cervical carcinoma, where you need to know about increased risk in HIV positive women caused by human papilloma virus. Regular screening in these patients is very helpful, and early detection can prevent its progression with an appropriate treatment. So this completes your opportunistic infections and the carcinoma in HIV. There are other long list, but mainly what is focused from the MRCP perspective are these are the things which you need to keep in mind.
Sir, one question.
Yes.
Regarding post-exposure prophylaxis and pre-exposure prophylaxis.
Yeah, we actually that covered. Let me take you to that. We covered last time that. Let me cover again.
The next question is toxoplasmosis. CT and MRI imaging. How can you differentiate diagnosis? in toxoplasmosis?
So they say there are different classic textbooks say starry sky appearance and there is a edema. However, practically when we have treated the patients, it is very difficult, and you have to keep it differentials on that, especially when the toxoplasmosis, if it's multiple ring enhancing, then you are very near in treating it, saying that it is a toxoplasmosis or cryptococcus. However, if it's a single ring enhancing and there are few other things which are not much detectable, they're very small, there are sometimes doubtful, the radiologist is not sure whether this is there or not, then it becomes extremely challenging. So in that case, you have to rely on other serology. And to be very honest, we have treated both cryptococcus and toxoplasma together, along with the steroids, thinking that, okay, whatever it is, let's go on with this. So you're right. Though the textbook says that the classical picture is the presence of ring enhancing lesion deep down into the white matter. Some the cryptococcus will come as on the surface, and it will be a less ring enlarging. They are small in size. These are big in size. But to be honest, these are never ever been reported as a clearly differentiating features.
Sir, another question.
Yeah.
How can you differentiate PML from HIV dementia?
So PML will have a classical MRI features where there is an involvement of the white matter, and the white matter hyper enhancing lesions are seen diffusely across the cerebrum. These are the MRI features. So you need to have an MRI. If they are not there, well, again, in HIV, dementia per se also will doesn't have any classic radiological feature. But if it's a PML, then you're looking at these MRI features. If they are not there, then probably you're looking at dementia. I'm just sharing about the post-exposure prophylaxis. This is what you're talking about? Post-exposure prophylaxis. So the standard UK regime is once you have an exposure, and this is especially for the needle prick, and when you have those HIV samplings been taken for both, then it is given within 72 hours of the exposure, and the standard regime is for the 4 weeks. It comes as a Truvada, it's a triple drug regime, or Caletra, and these names are specific for the UK people. But this again, this is not a replacement for the safer practices, of course. This is what you are asking?
Yes, sir.
Yeah. So from exam perspective, these are the things which you need to keep in mind. Of course, for Indian regimes, and every hospital has its own. WHO has a slightly different regime, and IDSA also has a slight, but more or less they come down to the triple things only. Due to be given within 72 hours.
Sir, one question. In HIV,
Yeah.
biliary tuberculosis is possible there?
Your voice is little bit breaking. I'm trying to understand what you're saying. Say that again.
Sir, in HIV, biliary tuberculosis can occur.
So again, as I said, extranodal non-pulmonary manifestations is massive in HIV. So it lymph nodes, you think of miliary, you think of any tuberculosis, it is possible. The class, what is not very common is the classic cavitatory upper lobe region of the TB. That is one thing which is not classically common in HIV for obvious reason. But rest of them, right from GI tuberculosis to just the lymph nodes to the miliary involvement, everything is possible. In fact, we have seen also that. And it becomes a very challenging affair.
Sir, why back is very serious than classical tuberculosis in HIV?
microcellum avium.
Microavium cell.
Yeah, yeah. See, this organism becomes it is ubiquitous, and usually it is a very low pathogenic. However, when you are looking at MAC, that means the host immunity is extremely bad. So the first and foremost thing that the immunity levels are so low itself gets into the high morbidity mortality. Second thing, by the time you think and diagnose that this is MAC, which is most of the time you require a stool sample. First of all, it has to be in your differential. These people will come as acute gastroenteritis, abdominal pain, and you are thinking about the CMV, cryptococcus. Your thought process is going in that direction. So by the time you have treated all these things and the patient has not responded, and by the time you realize, oh, let me think for MAC also, the time is already gone. So it is not that. If you keep it on the top, if you treat them empirically with this also, many a times these patients get empirically treated with azithromycin, clarithromycin, and tuberculosis thing. So it automatically gets covered. But if you are asking me pinpoint question that why it is bad, it is more mainly because it's a late diagnosis or difficult to diagnose.
Yes. So CD4 count is much less in the MAC.
Correct. So now again, so if the CD4 count is very low, right? So it doesn't mean that those with the CD4, those organisms which we commonly see from between CD4 50 to 100 or 100 to 200 or 300, they won't come. No, this is in top of those organisms. So the list of your differential diagnosis keeps going up as the CD4 counts keeps going down. And that is the reason. So there is no rule to say that, oh, it is CD4 less than 50, so less likely CMV, it is more of a MAC. No, it doesn't happen. It can be simple salmonella also, or it can be simple bacterial gastroenteritis also. But beyond that, and you will treat that also. But beyond that, you have to also add this organism to your differential when you are dealing with such a low CD4.
So why in Cryptococcus meningitis sometimes rigidity is not there? It is the cause.
Rigidity.
Yes. Rigidity in case of Cryptococcus meningitis.
Correct. So it is not only for Cryptococcus meningitis. It is for any meningitis happening in an immunocompromised or immunosuppressed state. See, your rigidity is the inflammatory response of the meninges to your infection, right? So for that, you need to have your immunity intact. Are you treating, if you're treating these patients concomitantly with the heart, and if these patients comes with the iris syndrome while you're treating, you may get all the classical signs and symptoms: encephalitis, meningitis, meningoencephalitis, everything. That is again a possibility. But when you're looking at an immunosuppressed, compromised state, when your inflammation itself is not getting triggered, then it becomes very difficult to diagnose, because these people will not be having. And same thing happens, even the classic textbook says, even for a normal immunocompetent patient, extremes of age like kid or elderly,
Yes.
you may not get it.
Yes.
Why is that? That is because your inflammatory response is not strong enough. Yes. Now here you are talking about an immunosuppressed, compromised person. That poor fellow is not even able to mount any kind of inflammatory response. So these people getting in classic ARDS, septic shock, this classic things is less. These people will directly surprise you by complete collapse cardiovascular. So that mounting and building doesn't happen. They may not get fever also.
Yes.
It makes sense?
Yes, yes. Sir, why pneumothorax presents as a complication of PCP?
Correct. So I think I put this slide here in the PJP. Right. So I put this line very specifically. PJP damages alveolar epithelium and reduces compliance and gas exchange. So when you are looking at the alveolar epithelial is completely damaged, then this simulates something what we call it as any streptococcal infection, staphylococcal infection, which causes a bulle, right? And this is, if you really want to imagine how it is like your COPD patients, where all your alveoli epithelium get destroyed and you start getting big bulle. So when you get, and this was also, if you, I don't know how much your exposure to the COVID was. In these COVID, people also had the similar issues. So they were having big bullets which were coming up because the alveolar epithelium was getting destroyed and all the alveoli were becoming a common big alveoli and they were becoming thin. So these people become subject to straight away subject to the pneumothorax because of the rupture of those villi.
Yes, sir. Thank you. So, last question, my last question.
Perfect. You are the only one asking, so don't worry.
Yes, yes. What is the, which one is pathognomonic in case of HIV regarding candidiasis? Whether it is oral candidiasis or esophageal candidiasis? Which one is pathognomonic?
No, there is no pathognomicity for the HIV per se. What common presentation is there that we can do it, because pathognomonic, when you say when you use the word pathognomonic, that means it becomes an age defining complex. And when you talk about a candidiasis, it is not age defining. Yes, your low immunity is there, you get oral thrush, you get esophagitis, that is true. The second thing, which is, if you want to consider it as a pathognomonic, is these patients, instead of white curdy thrush, they have more red color ulcerative lesions. That is more pathognomonic you will see in HIV. So the fungal infection coming in HIV may not be as classic as a white oral thrush, but you may get red color ulcerative lesions on your hard palate. And if you do an endoscopy, it will be mainly the esophagus and esophagitis, particularly in the lower one third. So that becomes, if you want to call it as a pathognomy. Yeah,
Yes,
Rishikesh Jha has used the right word, pneumatoceles causing pneumothorax.
yes, yes. Sir,
Neeraj,
excellent. Excellent, sir. Thank you, sir.
welcome. Neeraj Banner has asked how to manage anti-tuberculosis treatment with patient is on heart. Now that is a very good and very the big question you are asked. And to be honest, no amount of theoretical reading is going to help you, because the complex interaction you are going to come across the drugs and the disease process itself. So unless you have worked under someone or worked on these kind of patient, you will be surprised to see the amount of interaction you get with 4 drug or 5 drug or 6 drug ATT with 3 drugs or 4 drugs or 5 drugs. So essentially, you're looking at minimum interaction of 5 AKT drugs with 3 to 4 hard drugs, which is like 9 drugs interacting among themselves to a disease called tuberculosis, which can come as a disseminated, including liver, complicated by inflammatory response syndrome. And to be very honest, I learned my whole medicine in one of my boss was very active in treating tuberculosis patients and HIV patients, and we had a whole lot of things, and we have seen all sorts of things you can think of when it comes to the treatment. So unless and until you have if you want to, if for the theoretical limit, this is what you need to know. But if you want to really practically see work under this kind of thing, you will really learn the medicine there. Uh, Rishikesh Chai has again commented. Yeah, no pustule in herpes, no cardiac complex in candidate. Correct. That is what I said. And reddish lesion with ulceration. They are, yeah, giveaways in it. Yes, correct. So this is what, if you may allow me to share, this is what I had said when it came to Candida. If I have seen, can you guys see oral thrush, vulvaginitis treatment is there.
So you had mentioned this in herpes that
Yeah,
there are no pustules.
correct. Oh yeah, I must have mentioned some hepatitis, CMV, herpes. Yeah. So genital oral. So presentation is more ulcerative than pustular, and that is for the herpes. And when you talk about the candidiasis, you may get oral thrush, but the red color ulcerative lesions you see in the oral and the lower end of the esophagus. Yeah, that's what you see in this. Correct.
I think there will be not more certain questions. I think Anand sir, if there will be
Sure,
any
sure.
more questions, then please aspirants, you can ask now.
Just tell me, was this the whole 3 sessions any useful? I don't know how many people were there before.
I think so some
Well,
of
the
them are.
sessions were really good, sir. But the thing is, I think in our setup, with very few cases of full-blown AIDS and other things to see,
Correct.
this is one of the most neglected topics, and we don't know much about it actually. So whatever you have taught us, that's a good stimulus for us to read further.
Yeah.
And I guess if we get any further questions, then we'll revert back to you, sir.
Please revert back. I can say a bit authoritatively. My whole general medicine, I learned it on HIV plus tuberculosis patients. To be very honest, I have seen all the complications right from male to hair, because my consultant was during that time there were no special training happening, and a brilliant physician, and all the brilliant physicians were excited with HIV/AIDS because that was stimulating their whole physiological presentations, the complex interactions of the immune cells was amazing, and that was a time when heart was just getting introduced. So this is like late 1990s, early 2000s. So that was amazing. So it
You
takes
will
me back.
you were actually, sir, very lucky in that regard. Like
Absolutely,
most,
absolutely. I agree. I was very lucky on that, because now you
yes.
don't see so much. Now you don't see with the heart coming up, somebody coming with, especially in a developed or developing country like us, or in the UK or in other Western countries. It's very difficult to see somebody with waiting for the CD4 count to go down like 100 or 50 and get all this kind of things. You can still get, if you're interested, might get your electives in some remote African countries, and you probably might get it. But even in
Yes,
rural India, now
yes, sir.
things are very, very, very well
So,
monitored.
and moreover, the thing is like most of these patients, once they are diagnosed, they are referred. So only the bigger centers they get to see these patients. So
Correct. But I would like to mention that when these patients, yes, they go to bigger centers to diagnose, but the specialist would refer them back to the primary physician. And so it becomes a very imperative for the primary physician to know. You may not have seen it, but you, as you say, that the eyes don't see, the mind doesn't know. So if you have even the slightest idea that, no man, I am treating this kind of thing is there and this kind of thing exists, something is not exactly fitting, then that is enough for you to pick up the phone and call back to the specialist and, hey, this guy seems to be worsening, even though he's on anti-TB treatment and I started on heart therapy, and he's becoming more breathless and all those things. And suddenly, if you remember, "Arey, no, this can be iris." So if it's there in your mind, you will definitely know it. You may not see it, unfortunately. Everything.
Absolutely, sir. But wonderful, sir. Wonderful classes, sir.
Thank
I
you.
attended all the three. Really blessed to have attended those.
Thank you. Thanks a lot.
Thank you very much, Anand sir, and rest of the aspirants to have your patience. Thank you very much.